I shall be talking about chronic osteomyelitis. As the name says, chronic. This means that this is the long-standing infection of the bone, and the organisms causing chronic osteomyelitis are Staphylococcus aureus. This is the most common organism. Staphylococcus epidermidis, E. coli, Streptococcus, Proteus, Pseudomonas, and tubercular bacilli. There are three types of chronic osteomyelitis. Chronic osteomyelitis secondary to acute osteomyelitis, Gary's osteomyelitis, and the Brody's abscess. On pathology, acute osteomyelitis leads to chronic osteomyelitis due to when the patient presents late or there is inadequate treatment of acute osteomyelitis. The pus will spread in the medullary cavity and subperiosteally, and then there will be death of the part of the bone which is called sequestra, and the cancellous bone destruction will occur, which will lead to the formation of cavities, and these cavities and sequestrum leads to persistent infection. Type and violence of the organism. When the body's immune system is competent but the organism is very violent, it can lead to persistent infection. When the patient has malnutrition, they have compromised body's defense, which can lead to persistent infection. When the infection persists, host bone generates more and more subperiosteal new bone formation, and then new bone formation will lead to thickening of the bone, and this subperiosteal new bone formation is in irregular fashion, due to which osteomyelitic bone has irregular surface, and since there is continuous discharge of the pus, it forms a sinus, and with time this sinus tract gets fibrosed and sinus becomes fixed to a bone. Sequestrum. Sequestrum is a piece of dead bone surrounded by microorganism and the granulation tissue. This presence of sequestrum is pathognomic for chronic osteomyelitis, and due to necrosis, this piece of dead bone separates as sequestra, which size varies from small spicule to large segment, and this sequestrum is lighter than the normal bone, and sequestrum acts as a needles, and this is the most common cause of non-healing sinus. On X-ray, this sequestrum appears dense. As it is dense, it appears more white on X-ray. As on the dead bone, demineralization does not take place. And sequestromy should be done for the removal of the sequestrum. And to carry out sequestromy, at least 2/3 surface of the sequestrum should be surrounded by involucrum. Now I will be telling about involucrum. Involucrum. Around the sequestrum, granulation tissue and the organism, reactionary new bone will form, which is called involucrum. This is the live normal bone. In this, there may be the hole to drain pus, which is called as cloaca. On clinical feature, patient presents with chronic discharging sinus, and the discharge vary from seropurulent to thick pus, and the patient will give history of bone piece discharge from a sinus, which is diagnostic, pain and pyrexia. On examination, there will be chronic discharging sinus which is fixed to underlying bone, and there will be multiple openings with piece of dead bone, and there will be thickened irregular bone due to new subperiosteal bone formation. There will be tenderness and puckering of skin, excoriation and deformity will be seen, and the adjacent joint will be stiff. On investigation, we do the radiology where we can see the thickening and irregularities of cortices and patchy sclerosis. Bone cavity is seen, which is the area of rarefaction surrounded by sclerosis. Sequestrum can be seen, which appears denser than surrounding normal bone, which means that it appears more white than normal bone, as decalcification do not occur in the dead bone, and as sequestrum is surrounded by the granulation tissue, it is seen as radiolucent zone. Involucrum and cloaca may be visible, and if there is pathological fracture, it can also be seen on the X-ray. On blood investigation, total blood count is increased only in acute exacerbations, and ESR-CRP is increased. On pus culture, there may grow causative organism which will help in selection of the antibiotics. And when on X-ray, we cannot appreciate where the pus is coming from, then we perform sinogram. In sinogram, we introduce a thin catheter on the sinus, and as far as it can go, then we inject radiopaque dye, and X-ray is taken. Radiopaque dye moves in the direction of infection, from where we can know that where the abscess is coming, which cannot be appreciated on the X-ray. Then we do the bone scan, where we compare the bone densities. Then we perform the CT scan, the MRI to see the sequestrum and bony cavities which cannot be appreciated on the X-ray. On treatment, our principle of treatment is primarily surgical, as antibiotics are useful only during acute exacerbation and post-operative period. Our aim of surgery is removal of dead bone, elimination of dead space and cavities, and removal of infected granulation tissue and sinuses. And the operative procedures are sequestrectomy. If it is in the medullary cavity, window is made on overlying involucrum and sequestrum is removed. Suturization, as the bone cavity formed is non-collapsing cavity and which causes persistent infection, so cavity is converted into suture by removing its wall, which allows free drainage of the infected material. This cavity is converted into suture and free drainage of the infected material. If function is not compromised on excising the bone, excision of the infected bone can be done. And amputation can be done if sinus undergoes a malignant change. Dead space reconstruction. Porous antibiotic impregnated beads can be kept. Bone cement, polymethyl methacrylate can be kept. And cancellous bone grafting can be done. Muscle flap transfer and bone transport, Elizarov method if large gaps are present. And aftercare, continuous suction irrigation system for 4 to 7 days, keeping 2 drainage tubes, inlet tube for antibiotic irrigation and outlet tube for suction pump. On complications, there may be acute exacerbation. Flare of the infection occurs commonly and it is treated with rest and antibiotics. Growth abnormalities can occur, which is shortening when growth plate damaged, lengthening due to increased vascularity of growth plate, and deformity when the growth plate gets damaged. It may cause pathological fracture and joint stiffness because of scarring of soft tissue, and sinus tract malignancy can occur, rarely squamous cell carcinoma, and amyloidosis, which is the late complication. And the differential diagnosis can be tubercular osteomyelitis, soft tissue infection, and Ewing sarcoma. This is all about chronic osteomyelitis. Thank you.